All right, we're going to start out with an approach maybe many of you haven't seen. Steve Murphy's been doing this for a long time. Steve's in Boston. He's going to talk about superior approach to total hip replacement. He's done about 3,500 cases. Steve's been tracking his cases since we met after he finished his fellowship probably close to 30 years ago now. Steve?
Good evening, and thank you all for hanging in. I'm delighted that at least the superior hip approach was on the list, even if only 6 or 7 people were saying it. But that's huge progress. I'll do a little introduction here. So an ideal operation, extensile, you can put any femoral component in, any acetabular component, preserve the soft tissues, do a trial reduction, check your tissue tension and your stability, and minimize intraoperative dependence on radiographs. Further, it's important that you should be able to apply this operation to virtually all of your patients, and I would say that the superior hip exposure meets all of those criteria. So what is it? Up until this point, I started doing this sort of trying to develop a technique in 2002, kind of locked it down in 2003, evolved from 25% to 50% to about 100% since then, and now have done about 3,500 of these. The technique, lateral position, incision can be long if you're starting out. Even a longer fascial incision would make it a lot easier, but basically you spread the max, find the back of the medius and bring that forward. Find the piriformis and either retract it or incise it. Bring that backwards. There's the minimus. You just bring the minimus forward. And then you have the entire hip joint capsule exposed. You make an incision in the superior hip capsule from about 12 to about an hour behind noon. Put retractors inside the capsule at that point. And it can be broach only, Riemann broach, any kind of stem, straight, curved. Get access to the canal, open up the top, and broach in situ. And then once the broach is placed, transect the neck and then excise the head. Once the head is out, you get your acetabular exposure with spiked impacting Hohmann retractors front and back and anterior superiorly. Take out the labrum, ream the socket with an angled reamer, and just about any type of angled cup impactor will work to put the cup in. Why excise the head instead of dislocating? Well, the reason for that is because you can preserve the soft tissues around the hip joint better. If you have to dislocate the hip, you have to disrupt the tissues or release them, one or the other. So it's just a more tissue-preserving technique. Once we've done that and put the cup in, then we do a trial reduction and switch the trial for the real stem and then close the capsule anatomically. In terms of clinical results, we published in the instructional course lecture series. And briefly, if you compare it to all the other exposures, including particularly anteriorly, the dislocation rate is lower at less than 1 in 700. The wound IND rate is lower at 0 in 3,500. Deep infection, 0 at 1 year in 3,500 patients. Those are, granted, there are not a lot of sickle cell and people on biologics, but still, it's very low. I think we talk about economics a lot now, so I thought I'd focus more on that. It's kind of interesting. We have all the economic data from CMS and looked at 3.5 years a while back. This is all part A for every total hip that was done in Massachusetts for 3.5 years, which was fun to look at. It's over 100 surgeons. This is a busy slide, but basically this is every surgeon with a reasonable amount of volume, and I'm just showing all the different categories, acute, inpatient, skilled nursing facility, etc. And if you look on the lower left-hand side, which are the lower cost group, in every single year from 2013 to 2016 and a half, the superior hip patients had the lowest cost. And you can see all those different categories. And so this is over 100 surgeons, about 120 surgeons, and every single year it was the same. If you look at total cost on average, it was $7,000 less on whatever it is there, $23,000 for 90 days, and it's $7,000 less, which is a very significant percentage considering half of those costs are fixed. And you can also see that it's statistically significantly lower in all of these categories: inpatient costs, skilled nursing, home health, readmission, and overall cost. If you look at private insurers, and Rich, I mentioned Rich Iorio, I had some of this data. This is private insurers in Massachusetts. If you compare these to patients that are operated on at the Brigham or at Mass General, which I think is funny to compare, this is a particular private insurer, $14,000 less over in a 90-day period for their cheapest case, and $22,000 less per operation for their more expensive cases. So that's a lot of money. That's almost twice as much. So in summary, I think both clinical outcomes and economic data show that you can get very low complication rates and do what can be a simple procedure with minimal technology in terms of radiographs in surgery with a low dislocation and fracture and reoperation rate. Thanks very much.
Thanks,